Hi, on today's live session, we are going to talk about atrial fibrillation and the pros to atrial fibrillation questions when we are attempting USMLE exam, not only in USMLE exam but also in real life. We will talk about management, we'll talk about its pathophysiology, we'll talk about what to do when we have a pre-op patient and he's being treated for atrial fibrillation and how to adjust his anticoagulants uh, ba- based on the risk factors. So, if we talk about atrial fibrillation, it is basically caused by the bearing foci that develop in left atrium, mostly at the site of pulmonary veins, and these lead to the irregular heart rhythms that cause irregular heart rate, and this further leads to irregular pumping of blood. The question arises that why atrial fibrillation is so dangerous or needs to be treated on urgent basis. The reason for that is that it causes blood stasis, which leads to coagulopathy or blood clotting. And if the atrial rhythm or heart rhythm readjusts or comes back to the normal, and those clots, if they go back to brain or they can go to intestines, they can cause brain stroke or acute mesenteric ischemia or maybe heart failure. So that is why we need to treat atrial fibrillation on an urgent basis. Whenever we have a question, we have to understand that the patient presents in ER or maybe in your office with irregular heart rate. You have to understand what are the comorbidities that have led to atrial fibrillation. Like it could be thyroid problem. Hypothyroidism is one of the most common cause of atrial fibrillation. It could be the defect in left atrium or in heart, like acute rheumatic fever or chronic rheumatic fever that have led to changes in mitral valve and further to the left atrium. It could be heart failure that have led to dilated cardiomyopathy. So all the structural defects in the heart lead to atrial fibrillation because there are structural changes in the heart. So those changes or those comorbidities need to be identified too. We have to treat the root cause of the atrial fibrillation, not only just the atrial fibrillation, but also treat the root cause. So, if we are talking about USMLE, because our basic purpose of making this video is for USMLE exam approaches, when we get the US atrial fibrillation question, the questions most of the time have ECGs, and these ECGs have two of the most important signs, I can say, like more discernible P waves. We call those fibrillatory waves. There are QRS complexes are irregular, so you have to identify based on these two things that whether the it is atrial fibrillation or some other arrhythmic issue. Secondly, the patient will present with palpitations. They can present with irregularly irregular pulse. So these are also the major signs. Once you make the diagnosis in the question, then you can further go to the options, rule out the answers. Another question arises, or the second part of our video is about management. We manage atrial fibrillation with the help of two techniques or two modes. These are rate control or rhythm control. For rate control, we use antiarrhythmics like beta blockers. We use calcium channel blockers, verapamil, diltiazem, and we also use digoxin if the patient has history of heart failure with reduced ejection fraction. We would never use amiodarone, I'm sorry, calcium channel blocker, diltiazem, or verapamil for heart failure with reduced ejection fraction because that would further lead to reduced preload, so or decreased pumping, and would lead to uh, increase in heart volume that would further lead to heart failure. So never use It is contraindicated if you have heart failure with reduced ejection fraction. Don't use verapamil or diltiazem. Use digoxin. Otherwise, you can use beta blocker if the cause of atrial fibrillation is hypothyroidism. Okay, and another technique is if the patient's atrial fibrillation is not controlled on heart rate control techniques, then we have to use antiarrhythmics. That's called rhythm control. Most commonly, we use amiodarone and flecainide. Now, amiodarone is type 3 antiarrhythmic, and it has side effects in lungs, and it is contraindicated in COPD. So never use amiodarone when the patient has COPD history. Okay. Another thing we have to keep in mind is how the patient presents. If the patient is hemodynamically unstable, the heart rate is very high, and the patient's BP is very low. No, we won't go for the uh, oral rhythm control or rate control. We would go with the electrocardioversion version that would correct the rhythm because the patient is hemodynamically unstable. We have to stabilize the patient. So that's also very important part in management. Another important thing about management is that you have to add anticoagulants in the atrial fibrillation patient. The reason for this is that whenever the heart has irregular rhythm, it is not pumping correctly. Most of the time, it's just pumping irregularly, not pumping properly, so the blood stays in stasis. If the heart pumps correctly, all the blood moves up and more bloods come down and then moves up to the body. But whenever it has irregular rhythm, it is not pumping correctly. So you have to give anticoagulants so the blood is not, if the blood stays in stasis, it doesn't form clots. So two of the most important classes of anticoagulants have been given. These are obviously vitamin K antagonists, which are which is warfarin, and it had another class is heparin, another class is direct oral anticoagulants that act on 10 inhibitor like apixaban and rivaroxaban. And in the start of the video, I've told you that we will discuss about the anticoagulant role, when to stop anticoagulants when the patient is pre-op. We have to stratify or classify the patient into two types, whether the patient is taking direct oral anticoagulants or whether the patient is taking warfarin. So if the patient is taking direct oral anticoagulants, we have to see if the surgery is high risk for bleeding or low risk for bleeding. Most of the time, the thoracic surgeries, the abdominal surgeries, the heart surgery, the renal surgery, these are the high risk surgeries that can cause more bleed. So another type of surgeries like biopsies, okay, we have to put uh, I can say catheterization. These are low risk. So we have to classify whether the surgery is high risk or low risk. Further going into going deeper into the classification, if the surgery is low risk, then we would, or minimal risk, then we will only stop the anticoagulant on the day of the surgery. If the surgery is high risk and the patient has also high risk for thromboembolism, if his cardiovascular score is more than 4, he has previous stroke history more than 3 months ago, then we will rate it as middle risk or moderate. If the patient has cardiovascular score more than 7 and stroke history less than 3 months ago, then we will rate it as severe thromboembolism risk. So on basis of this, we will stop the anticoagulant on the day of the surgery. Otherwise, if the patient has minimal risk, we will stop the direct oral anticoagulant 2 to 3 days prior to the surgery. Okay, that's the detail for direct oral anticoagulants. But the scenario is a bit different for warfarin. If the person has low risk for the bleeding or minimal risk, then we will stop the warfarin on the day of surgery, and there would be no need to bridge it with heparin. And if the patient has moderate to severe risk, then we will be bridging warfarin with heparin. Now we have already discussed that what's the severe risk for thromboembolism, what's middle moderate risk, and what's the low tier risk. The severe one is chest vascular score more than 7, along with stroke history less than 3 months ago. The moderate is chest vascular score less than 7, maybe 5 to 6, and stroke history more than 3 months ago. And about the lower, it's chest vascular score less than 4. So that's how we stratify how we stop the anticoagulants before the surgery in the atrial fibrillation patients. That's something USMLE sometimes tests in the exam, that when you have to stop the anticoagulation. Whenever you are treating the patient with atrial fibrillation, anticoagulation is most integral part of the treatment. Also, if you have to cardiovert the patient, you have to give anticoagulant, because if there are already clots formed in the heart when the rhythm was irregular, that cardioversion would lead to stroke, can lead to mesenteric ischemia, it can lead to heart attack. So never forget anticoagulation when you are treating atrial fibrillation. So I think that was all about today's video. I'll just give the quick recap. In atrial fibrillation, we treat patient with rate control or rhythm control. Mostly we go with rate control first, with beta blockers, with deltaism, with verapamil, that are calcium channel blockers. Then, if the patient has reduced ejection fraction heart failure, we go with digoxin. If the rhythm is still not controlled, or the rate is not controlled, or atrial fibrillation is not being treated effectively, then we go to the antiarrhythmics. Most common are amiodarone and flecainide. We don't give amiodarone in COPD. Then, if the patient is hemodynamically unstable, we will go with electric cardioversion. But along with that, we have to give anticoagulation. That could be warfarin, but we don't give warfarin in acute conditions, because warfarin takes 2 to 3 days to come in action. So we will go with heparin or maybe direct oral anticoagulants. Then we have talked about the surgery. If the patient is on direct oral anticoagulants and he has atrial fibrillation and he has to go for surgery, if the surgery is low risk for bleeding, just stop the anticoagulants 2 to 3 days prior to the surgery. If the surgery is moderate to severe risk for bleeding, that are renal surgery, cardiac surgery, thoracic surgery, abdominal surgery, then go for stopping the anticoagulants on the day of surgery. Now, if the patient is on warfarin, you have to stratify if the surgery is minimal to low risk. Stop the warfarin on day of surgery. If it has moderate risk, stop the anticoagulant warfarin, bridge it with heparin. And we have also discussed the tiers. These are low, moderate, and severe. The lower is chest vascular score 4, moderate is chest vascular score 7, less than 7, along with stroke history more than 3 months. Severe is chest vascular score 7, stroke history less than 3 months. So these are some basic algorithms you have to remember when you are treating patient with atrial fibrillation. I think that's all for today. In the next sessions, we will be discussing more heart problems, antiarrhythmics, and arrhythmias, especially, and how to approach these questions in not only in the USMLE exam but also in real life. Thank you.